All right, and thank you again for being here, everybody. We're excited to have you. In the past, while we've been gearing you up to learn some embryology and histology, we haven't had as much overlap between presentations, but I'm really excited for today's because we get to learn a lot about muscles and the musculoskeletal system. So we'll be getting a lot of that today, and you should be masters by the end of all of it. So thanks for being here. A couple of housekeeping items is that if any of you haven't been getting the information from Toltec to register, then please go ahead and email their customer service line. It's found on their website, which is also linked on our website, just to make sure that you guys aren't missing out on this awesome opportunity from Toltec. So go ahead and update that if you guys haven't gotten the access link sent to your email. The other thing is I'm happy to announce that we are at almost 500 participants in our inaugural Anato-Bee. So that is really awesome that so many of you are interested in learning about anatomy. We're so excited to have you here. And no matter what level you're coming in at, I think this is going to be a great opportunity as you guys are getting along into your healthcare professions and figuring out where you guys want to apply to colleges. So thank you again for everyone for being here. So with that, I'll turn things over to Dr. Frank.
Hey, hello everyone. If you haven't been here before, I'm Dr. Bill Frank. I'm at the Drexel University College of Medicine, and I'm going to be your humble host for the evening. And without further ado, I will introduce our first presenter. Emily is going to be presenting the muscular system. So from Washington State, she is at college. She is a medical student at Drexel. She aspires to become free hiking, pole, and hanging out. Tell us what her cat's name is here.
My cat.
Cardiovascular system. Without further floor to Emmeline for anatomy of the muscular.
All right. Sorry, you were breaking up a little bit there, but I think it's my time. So I'm just gonna share my screen and then we will get right to it. All right, can you let me know if you can see my screen? Just give me a thumbs up. Okay, great. All right, so I'm Emmeline Whitwer. I am an M2 at Drexel University College of Medicine, and I'm going to be going over general anatomy of the musculoskeletal system. And we have quite a few learning objectives to go over, so it's going to be a bit of a sky-high overview, just because this is like so much. I feel like these objectives are stuff that it took me months to learn, so we're just gonna do the best we can. So the first is to define the concept of movers, antagonists, synergists, and to describe how each promotes normal muscular function. Then we will identify the fascial compartments of the upper and lower limb and generalized functions of the muscles within each compartment of the upper and lower limb. We will define and identify examples of tendons, ligaments, and superficial and deep fascia and aponeuroses. We will identify major muscles of the upper and lower limbs and general attachments and actions for each. And we will identify the major muscles of the back, neck, chest, and abdomen and general attachments and actions for each. And finally, we will identify the main peripheral nerves and arteries of the body respective to the compartments that they innervate. So we'll just jump right in. First, we'll go over the idea of movers, synergists, and antagonists. So when you go on and learn more about like pharmacology and just dive more into science, you'll learn that synergy is always like working with and antagonism is always working against. So it's the same idea, same principle applied here. A mover will be the primary muscle responsible for a movement. The synergist will help the mover, and the antagonist will work opposite of the mover. So I've taken the movement of flexion at the elbow to use as an example. So if you were to do a bicep curl and move your hand closer to your face. That is flexion at the elbow. So the primary mover for this is the brachialis, and you can see that is on the anterior side of the humerus. A synergist for this movement is, or a synergist muscle for this movement, excuse me, is the biceps brachii. And you can see that that is also on the anterior side of the humerus. So it kind of makes sense, like when you contract them both at the same time, you're going to be getting the same motion. Then there is the triceps brachii, which is an antagonist to the movement of flexion at the elbow. And the triceps brachii is on the posterior side of the humerus. So you can imagine that when you contract the muscles of the biceps brachii and the brachialis, you would have to relax the fibers of the triceps brachii muscle. Next, we'll go over what fascial compartments are. They are groupings of muscles separated from each other by connective tissue sheaths called fascia. There are 4 compartments in the upper limb. There is the anterior and posterior of the upper arm, and then the anterior and posterior of the forearm. So the basic idea is that the muscles that are, going to be acting in synergy are going to be grouped together, and they're going to be surrounded by this connective tissue, which is called fascia. And in the image on the right, I've shown anterior and posterior, and this is in the same muscles that we were just looking at. You can see, if you look closely, the biceps brachii on the anterior side and the triceps brachii on the posterior side, and they are separated by fascia into these different compartments. And just for fun, a clinical correlate is that when you have trauma to a compartment and you start bleeding, say, I think bleeding is a good example, into a compartment, pressure will build up inside of that compartment, and that can damage the tissue inside of that compartment. And so what doctors do is called a fasciotomy, where they relieve the pressure by cutting into the compartment and letting all of that blood come out, so that there's not as much pressure being built up inside of the compartment. And that's just a fun little fact. We'll now go on to the compartments of the lower limb. So there are 3 in the thigh and 3 in the leg. They are the same in that there's an anterior and posterior in both the thigh and the leg, but in the thigh, there's a medial compartment, and in the leg, there's a lateral compartment. And in the image on the right, they do separate into a deep posterior and a superficial posterior, but we'll just consider those just the posterior. So you can see where we are in the body. This is like a cross, where like we've basically cut the leg. You can see that we have the tibia and the fibula, so you can tell that you are not in the thigh, but you're in the lower part where the calf is. So I think that the best way to remember it is just that you have anterior and posterior for both the thigh and the leg, but in the thigh you have a medial compartment, and in the leg you have a lateral compartment. Now we'll go over what tendons and ligaments are. Tendons attach muscle to bone, and ligaments attach bone to bone. I think a famous example of a tendon is the Achilles tendon or the calcaneal tendon. And I have an image of that here on the right. The calcaneus is a bone in the foot, and it's attached to these muscles of the calf. The soleus and the gastrocnemius muscles are attached to the calcaneus in the foot by way of the calcaneal tendon or the Achilles tendon. Some famous ligaments are the ACL and PCL. You may have heard of an ACL tear. It's a very feared sports injury because it can take you out for quite some time. So you may even know someone who's torn their ACL. It's a very, very common injury. And in this image on the left side, you can see just barely the ACL coming down here from the femur and attaching to a more anterior aspect of the tibia. And you can, I mean, just barely see the PCL. You can see it better here on the right side of this image. The ACL, we're looking down at the top of the tibia, and you can see how the ACL attaches to the more anterior aspect of the tibia, and the PCL attaches to the posterior aspect of the tibia. And now I'll just go over superficial versus deep fascia. The superficial fascia is going to be the fascia that is directly beneath the skin. And then the deep fascia is what makes up the compartments that we talked about, as well as it wraps individually around the muscles. So you could think of this as superficial is right below the skin, and then the deep is every other part of the fascia. Aponeuroses are a thick and very tough connective tissue. One example I have here on the right is the palmar aponeuroses. And when you do dissection and you get to see it, it's very, very thick and shiny, and just more noticeable than other types of connective tissue because it's so substantial. It's really cool to see. We'll dive right into muscles of the arm, the upper limb. On the left, we have a posterior view. So we're looking, say, like at someone's back. And on the right, we have an anterior view. I think it's important to know the muscles of the rotator cuff. They're famously known for the acronym SITS. S for supraspinatus, I for infraspinatus, T for teres minor, and S for subscapularis. The action of the rotator cuff is rotation at the shoulder. On the posterior side, you can see supraspinatus, infraspinatus, and teres minor. Those are 3 of the rotator cuff muscles. And then you have to look to the anterior side of the scapula to see subscapularis. The teres minor and infraspinatus both do external rotations. You can imagine if you contract these fibers, you're going to rotate the humerus outward externally. And then we have subscapularis doing internal rotation. You can imagine that if you were to contract these muscle fibers, you would be rotating this humerus inward. Then you can also see in this image the triceps muscles here that we talked about earlier. And you can also see teres major, which is just below teres minor. And it does adduction and medial rotation similar to latissimus dorsi, which we will see in just a few minutes. I wanted to quickly do nerves of the upper limb. You can see on this top half of the upper arm, you can see the median nerve and the ulnar nerve. And then the radial nerve, you can see better down here on the forearm. So the median nerve is easy to remember because it's in the middle. Sounds like median. The ulnar is on the pinky side, and the radial nerve is on the thumb side. The ulnar nerve is actually the funny bone. So if you've ever hit this part of your arm and you have that shock go up, and it's called the funny bone, it's actually your ulnar nerve. So that's a fun little fact you can tell your parents. Now we're going to do the lower limb. So let's orient ourselves. On the left, we have an anterior view. We can see the patella here in the front of the knee, so we know we're looking anteriorly. On the posterior side, we can see just, I guess the sacrum kind of tips us off that we're looking at the posterior side. The anterior general action is flexion at the hip and extension at the knee. And the posterior is the opposite. It's extension at the hip and flexion at the knee. We know what the quads are. They are part of your thigh, and they're made up of 4 muscles. We can see 3 of them here. On the lateral side, we have vastus lateralis. In the middle, we have rectus femoris. And on the medial side, we have vastus medialis. There is a 4th one, but it is beneath rectus femoris, and it is the vastus intermedialis. And then we can also see the sartorius muscle, which I always think is fun because it just like wraps around. It's going a different direction than the other ones. And then tensor fascia lata. It connects to your iliotibial band, also known as your IT band. You may have also heard of injuries involved with the IT band. You can get a syndrome called IT band syndrome, where you have pain where the IT band inserts onto the lateral aspect of your knee. On the posterior side, there are 3 muscles of the glutes. There's minimus, medius, and maximus. We can see minimus here, and then medius and maximus have been cut. There are the hamstring muscles on the posterior side. The medial hamstring muscles are the semimembranosus and semitendinosus muscles. And then the lateral hamstring muscle is the biceps femoris muscle. Then we have on the posterior side, this big old nerve, the sciatic nerve, which is also really cool to see when you do an anatomy dissection because it is really thick and noticeable, very hard to miss. And it comes down and gives off some terminal branches. There's the peroneal nerve, also called the common fibular nerve, and the tibial nerve. And those are going to innervate different parts of the lower limb. All right, now going even farther down the leg, we have the muscles of the lower part of the lower limb, and we have anterior view here on the left, and then some posterior views on the right. The general action of the anterior muscles is dorsiflexion of the foot and ankle, and that means lifting your foot up. Posteriorly, it's the opposite. It's plantar flexion of the foot, which means like gas pedal. You're putting your foot down. So we'll run through what these muscles are real quick. On the anterior side, we have tibialis anterior, fibularis longus, extensor digitorum longus, fibularis brevis. On the posterior side, we can see the gastrocnemius muscles, which are the more noticeable muscles of your calf. When you think of flexing your calf, it's going to be your gastrocnemius muscles that you're feeling. And they've been cut here so that we can see the soleus, which is deep to the gastrocnemius muscles. Then we also have, if we go even deeper and we cut the soleus muscle, then you can see the muscles deep to it, which are the tibialis posterior, flexor digitorum longus, flexor hallucis longus, and we can see fibularis brevis from this view. We could also see it from the anterior view, and fibularis longus can also be seen in the posterior view, which we also saw over here on the anterior view. Now we're going to do back, abdomen, and neck. So the pectoralis major, your pecs, those are noticeable muscles that I think a lot of people have heard of before. They originate from the sternum and the clavicle, and they insert all the way on the humerus. So I remember thinking that was interesting when I was first learning it, because I just didn't know they went all the way over to the arm. And they are responsible mainly for adducting the arm, so bringing them in. The deltoid muscle It originates on the clavicle and the scapula. It inserts on the humerus, and it is the primary mover for shoulder abduction, which looks like this if you can see me. The latissimus dorsi is here on the back. It originates on a number of the vertebrae, inserts all the way up onto the humerus, and it adducts, extends, and medially rotates the arm. Then we look over here on the right, and we can see the trapezius muscle, or the traps. It originates also on a multitude of vertebrae, inserts onto the scapula and the clavicle, and it elevates and depresses the shoulder. So you can think that these more superior fibers, when they contract, they're going to be lifting, whereas these more inferior fibers, when they contract, they're going to be depressing. It also retracts the scapula. And we have deep to trapezius. So if you were to remove the trapezius muscle, you could see the rhomboid minor and the rhomboid major. They originate on the vertebrae, insert onto the scapula, and they will also retract and elevate the scapula. Now here we can see the neck muscles. There's sternocleidomastoid, which I think is the most important one to know for the neck. It originates, it's very aptly named because it originates on the sternum and the clavicle, and it inserts onto the mastoid process of the skull. So we love when things are named for exactly where they originate from and insert. The action of it was confusing for me when I first learned. It makes sense that when you contract bilaterally, both sides, you'll flex at the neck. That makes sense. When you contract just one side, it will rotate to the opposite side. So if I'm contracting my right, then I'm going to turn to the opposite side. And so I think that it's helpful to convince yourself of that by lightly putting your fingers right on top of your clavicle and turning your head to one side, and you can feel it's the opposite one that's contracting. Muscles of the abdomen, we have rectus abdominis. It's originating mostly from the pelvis, inserts on the ribs and the xiphoid process of the sternum. And its action is to flex the trunk. That's what we think of when we think of our abs. There's the anterior serratus muscle over here, originates on the ribs, inserts on the scapula, and the action is anterolateral movement of the scapula, and it also assists with accessory inspiration. So when you're really trying to breathe in. There's also the external oblique muscle, originates on the ribs, inserts on the linea alba and parts of the pelvis, and it acts to flex the trunk and does forced expiration. So opposite of the internal oblique, which is sorry, let me just move this. Which is to flex the trunk and forced expire. What? I'm sorry. Am I messing that up? The action of the external oblique and internal oblique, they should be opposite. Let me think real quick. They both do forced expiration, so we'll go with that. And if it is incorrect, we will correct it later. When we try to think of the direction of the fibers of the internal and external obliques, we can think of the phrase hands in the pocket for external oblique. So you're putting your hands in your coat pocket in front of you, and then there's hands in prayer, which is for the internal oblique, because these are going opposite directions, and they both act to flex the trunk. Lastly, yeah, there's a few more slides, but I wanted to go over the major arteries, which is a whole roadmap of arteries. And I think there's kind of like two ways to look at it. You can look at it by looking at the image, or you could make a flow chart. I think different people do it differently. I like the image. Some people are flow chart people, so I just put both up. Let's do, okay, so we'll start by doing the upper limb, how that has its blood supplied to it. And then we will go over the more central part, and then we'll do the limbs. So there are three main branches coming off the aortic arch. There is on the right side, the brachiocephalic trunk, and then on the left side, there is the left common carotid and the left subclavian. So that is different between the left and the right. So you have to try to remember that there's just one branch coming off the right side and there's two coming off the left. You also have to remember that in medicine, right is left and left is right, right? So we are looking at it, and on the right side, it is actually the patient's left, and on our left side is the patient's right. So that can also be confusing. So you have to get used to that. But we come off here on the right side, we go to the right subclavian, or the right brachiocephalic trunk to right subclavian, down to the axillary to the brachial. The brachial splits off into the radial and the ulnar. The radial will be on the thumb side, the ulnar will be on the pinky side, just as it was with the nerves. And here on the left side, we don't have to go to a brachiocephalic trunk first. We just have the left subclavian coming directly off the aortic arch. And then it's the same. Once we get past that point, and we can see here on the flow chart, subclavian to axillary to brachial to radial and ulnar being split off from the brachial. And these are all the same tube. You know, it's not like these are actually, they're just being named based off of where they are. So it's not like they're actually separate arteries. We're just naming them based off of where they are. When we look at the more central arteries, things make, I don't know, I think a little bit of sense. You're just naming the aorta based off of where it is. If you want to look at the right side and look at the flow chart, then that's great. If you want to look at the image side, then that's also great. We'll start with the image side and then we'll go through the flow chart. So you start here at the heart, go to the ascending aorta, becomes the aortic arch. We have the three, remember it's always three coming off the aortic arch. It's the brachiocephalic trunk on the right, and on the left, we have the left subclavian and left common carotid coming off. And once we become the brachiocephalic trunk, then we give off the right subclavian. So if you look here on the flow chart, you can see that we get to a right common carotid, a right subclavian, and a left subclavian and a left common carotid. So it's the same outcome on the left and the right, but on the right side, we have to hit a brachiocephalic trunk first. And that's just the fun anatomy of the human body. Once we go over, we'll go back to the image side. Once the aortic arch turns over, then it's the descending aorta. Then we're just naming the aorta based off where it is. So when we are above the diaphragm, we'll call it the thoracic aorta. Once we get below the diaphragm, we'll call it the abdominal aorta. Then it will bifurcate, means split, into the common iliacs. So we have here the right common iliac and the left common iliac. And the common iliac will give off the internal iliac, which goes a little deeper into the pelvis. And it will the common iliac will continue on as the external iliac, which will go down into the legs. So I think that just practice doing this by writing the flow charts out and then checking it. If you're a flow chart kind of person, I know they look sort of crazy. Or you could just be an image person and just, you know, look at this side of it. I think there's just two ways to do it. You could do both, but I think I think it's good to do the flow chart because you have to actually like come up with it like just straight from your brain. So now we're going to follow down into the legs. Remember, we left off at the external iliac. The external iliac will become the femoral artery. And then once we hit the knee area, then comes the popliteal artery. The popliteal artery will give off 3 tibial arteries: the posterior tibial, the anterior tibial, and the fibular, which you will also see named the peroneal artery. You will also see some places, you might be able to distinguish the common femoral becoming the superficial femoral, the common femoral also giving off the deep femoral. But I think that it's sufficient just to know that the external iliac becomes the femoral artery, becomes the popliteal artery. A fun way, this might work for you, it might not work for you, but I remember the popliteal artery being around the knee, because when you go down the stairs and your knees pop, if the knees are popping, then it's the popliteal artery have to be around the knees. That's just how I remembered that. You can see here that the 3 tibial arteries are coming off the popliteal artery. The anterior tibial artery comes directly off. The peroneal or fibular artery and the posterior tibial artery actually come off a tibio-peroneal trunk. But there is some anatomical variation in where the tibials come off of. So you might see differences when you get into the anatomy lab. Some people have a really short tibio-peroneal trunk and some people have a longer one. It's also called the tibio-fibular trunk. So anytime it's peroneal, it could also be called fibular. And does anyone have any questions?
Thank you, Emily. That was really great. Looks like we've got a couple. I'm not sure if Dr. Frank is frozen or not. But I'll just kind of go through some of these. We were getting some questions, sort of general questions about the anatomy, but I think we answered a lot of those ones in the chat. So as far as yours goes, we were talking about the external and internal intercostal, we've got our oblique muscles. And so you were correct in saying that we've got some flexion going on. And I liked that you had, going back to that slide, some expiration. And so I believe that the internal obliques are more associated with the forced expiration, but one rule of thumb to think about with any of these muscles is what the where their attachments are and how they can explain then what the function of that muscle is. So we haven't talked a ton about the origin and insertion here in terms of what that means, but for example, if I have something that is attaching for my arm, for example, if I have an anterior attachment point, then that's going to help. You can see how that would help me flex then at the elbow. So that's one that we were talking about. And so you can imagine if anything is attaching to the ribs, they might help move your ribs. And so even just a basic understanding of that can be very helpful to think about what the action might be. So going from there, what do we do often when we're moving our ribs? What is a function? Why would we want to be able to move our ribs? You're all doing it right now when you're taking breaths in and out. So, helping with breathing in some sort of way is going to be something that, I see, good job. We get that in the chat too, breathing. Yeah. So pretty much anytime we're attaching to the ribs, we're going to have some sort of function there for helping with breathing as well. And then the other action to think about with these oblique muscles is thinking about rotation. And so we're not just able to flex and extend our trunk, we can also rotate and twist side to side. So that's something that's kind of unique with the external and internal obliques, is that their origins and their insertions are actually contributing to opposite functions. So the external oblique is going to help me rotate to the opposite side. So if it's my right oblique, if that muscle contracts, it's going to help me twist to the left, versus if it's my internal oblique, it's going to help me rotate to the same side. So if I contract my internal oblique on the right side, I'm going to be twisting my trunk to the right side. So hopefully that cleared up some of those ones. We've got some study tips, and I'll let Emmeline take this one first. Is just any tips for studying, just because it's a lot of information, and obviously you've made it this far as a medical student, so I'm sure you've got some experience with this and sort of navigating this material for the first time. So what did you do that was successful for you?
Let's see. I think repetition is just really important when it comes to this volume of information. But I really do agree that thinking about where something originates from and where it inserts into can tell you a lot about its action. So if you get those origin and insertions down, then the actions of muscles tend to fall into place because it will just make sense. If you think, I mean, how we were going over the biceps brachii earlier, if you think about where that is on the body and where it's originating from and where it's attaching to, then the action of it will make sense. But I do think that repetition is really important. And just like being able to explain it to yourself, being able to explain something to a friend really solidifies information.
Yeah, I agree with all of that. I think part of doing really well academically is learning how to learn and being very humble about that process. And, you know, hyping yourself up and having that confidence, I think, is important. But I think it's also better for yourself to recognize maybe where you could use a little bit of help with some areas and taking some advice from other people in those ways. So one for me is that I wasn't spending enough time recalling it on my own. And so one thing that you might do is you look at the information and you think you know it because it's right in front of you. But that active recall that you were getting at is very important for learning. So getting past that superficial level of understanding is just being able to regurgitate what was on the PowerPoint. But getting to a point of understanding is huge for learning and showing that you know that information. And people who can do that and figure that out earlier on tend to do really well academically. So if you're already on that journey, then kudos to you for all your hard work in there. I see we've got a hand up from Michael. Do you want to either unmute yourself and ask your question or type in the chat?
Yeah, sure. Thank you. I had two questions. One was like for the superficial fascia, you mentioned it was just beneath the skin, and I know like the subcutaneous layer is just beneath the skin. Is that the same thing, or is it somewhere in between there? Like, is that the ground substance or something else? And then the second question I had was you mentioned like pressure can build up in the different muscle compartments. Is there any way for blood to travel from one compartment to another, or is it really just stuck in that one compartment until they do that fasciotomy?
For the first question, I will defer because I just can't remember.
There's a lot of terms you'll find that have numerous names to them. And so the subcutaneous tissue is going to include that superficial fascia. So that's that would be correct.
And then the deeper fascia around the muscles are the investing fascia. So there's superficial fascia, and then there's deeper fascia, and then there are septations between muscle groups, which help make up the compartments. And so there's fascia upon fascia upon fascia. And as far as the second part, Emmeline, did you want to talk about the compartments?
As far as I know, when like the fasciotomy is required because that fluid cannot leave. So
it's a closed compartment.
Yeah.
Yes. Mm-hmm.
Yeah. So I would say that the fact that a fasciotomy would be necessitated would mean that there is no way for that fluid to leave.
Those are great questions, Michael. Thank you.
And clinically, that's
great
too. If that pressure is building up, then we're compressing the other structures in that area too. So we use blood as one example, and that's definitely something that can happen, but could also be inflammation that can cause that. And then if that's the case, then you also end up compressing the arteries in there and you get reduced blood supply to where it needs to go. So there really could be numerous ways where that presents, but yeah, great job. Great question.
Great. Well, I think we need to move on to our second presenter. Emmeline, thank you very much for a fabulous presentation. So you can unshare your screen, and I'm going to introduce our next presenter, Kate Long-LaJoie. who is going to be presenting on histology of muscle tissue. Kate is back by popular demand. And if you had not been here before and met her, Kate graduated from Johns Hopkins University with a bachelor's degree in biomedical engineering and subsequently earned a master's degree from Georgetown University in biophysics and physiology. She now attends Drexel University College of Medicine. When not studying, Kate loves to travel the world with her husband, Mike, always returning home to her rambunctious pup, Lily. Kate believes that learning anatomy is like discovering a roadmap to all the fascinating structures that enable us to live and do what we love. So with that, Kate, I give the floor to you.
Thank you so much. Let me get this set up. And just on the line of my dog, she has been quite barky today, so I do apologize if you can hear her in the background. I will try to do my best to keep her under wraps, but it's, you know, there's only so much I can do sometimes, so. Okay. Okay. Can everyone see my screen? Yes, okay. All right, so we're just gonna go through the learning objectives to start. You guys did a great job hanging with all the learning objectives for that first part, and Emmeline did a really nice job explaining everything. This is gonna be a little bit more straightforward, so you can look forward to that. You know, as some things are harder, some things are a little bit more straightforward. So this is kind of into that category. So the learning objectives today are to compare the 3 different types of skeletal muscle. That's actually, I don't think that's correct because that should just say muscle. 3 types of muscle: skeletal, cardiac, and smooth, in terms of histological morphology, function, and typical locations in the body. Then we're going to correlate the molecular organization of the sarcomere with its history and function, histology and function in the skeletal muscle. And lastly, we're going to describe the organizational layers of skeletal muscle from muscle bundle to muscle fiber, including their connective tissue coverings. So I've organized this into 3 separate sections, one of skeletal muscle, one of cardiac, and one of smooth. So let's get started with the skeletal muscle. Histologically, the skeletal muscles are multinucleated and they form an anatomical syncytium, which is a cytoplasmic mass that contains several nuclei. So it's kind of a large mass of multiple cells that are working together kind of with a common goal. They're long and unbranched, as you can kind of see in this second image here. Can you guys see my cursor when I move it? Okay. So in the second image, you can see they're very highly organized. They're unbranched, and the nuclei are peripherally located, which is best seen here. You can see these purple elongated nuclei. The striations result from the arrangement of contractile elements that we will go through in just a moment that allow the muscle to produce movement. And then you can see here, there's a peripheral satellite cell, which is kind of like a muscle cell stem cell. So if the muscle gets damaged, that satellite cell can become activated to form new muscle cells. The function of skeletal muscle is under voluntary control, and it's controlled via motor neurons. And every muscle that Emmeline just talked about is a skeletal muscle. So they're the ones that let you move your arms, any voluntary movement. If you can decide to do it and you can decide to move, it's a skeletal muscle. Typical locations, again, are just grossly named muscles that attach to the skeleton and fascia via tendons and ligaments. You can see in these photos here, we're going to go through each organizational aspect of the muscle. But you can see the peripherally placed nuclei here. So those correspond to the purple elongated nuclei here. In between, you can see some connective tissue formed by the white. And we'll go through the organization. So you grossly have a skeletal muscle, for example, the deltoid muscle. That's what they mean when they say grossly named. They have a specific name. We don't necessarily name the like smooth muscles in visceral organs. They're just kind of the smooth muscle of whatever organ they are located in. Skeletal muscles are made up of muscle fascicles or bundles. And I've tried to organize this diagram so that it goes from largest to smallest visually as well, because I did find that helpful when I was learning. Muscle fascicles are comprised of muscle fibers or myofibrils. And you can kind of see that over here. You've got the gross skeletal muscle. Within each gross skeletal muscle are collections of these muscle fascicles. And within each muscle fascicle, as you can see here, is the muscle fibers or myofibrils. And the unit that makes up the muscle fibers are these, let's go to the next slide. Oh, we're not quite there yet. We'll get there. So I mentioned that every muscle is comprised of the muscle cells and connective tissue. The skeletal muscle, the gross skeletal muscle, just like a deltoid muscle or gastrocnemius, anything like that, is surrounded by an epimysium. You can see that here. It's surrounding the entire muscle. So if we were to remove that muscle or see it in a gross anatomy lab, the epimysium is what would be covering that entire muscle. The muscle fascicles, again, are the bundles that comprise skeletal muscle, are surrounded by perimysium, and you can kind of see that here. So this is fascicle here, this is a fascicle here, and between them, you can see a septate of perimysium. And then between the muscle fascicles, within the muscle fascicles are the muscle fibers or the myofibrils, each of which is surrounded by an endomysium. So from largest to smallest, you get epimysium, perimysium, and then the smallest is the endomysium surrounding each muscle fiber. And again, this is fibrous connective tissue. The white septates here are fibrous connective tissue, which the epimysium, perimysium, and endomysium are all comprised of fibrous connective tissue. So the smallest unit is the sarcomere, and this is the functional unit of the skeletal muscle. So myofibrils are comprised of groups of sarcomeres, which are made up of overlapping protein filaments. And this here is a pretty good representation, of a sarcomere with its labeled portions. The next photo is a little bit clearer, but we'll start here. So you have the M line, which is not labeled here. Yeah, I am going to go to the next photo here. So the M line is in the middle. The M line is the site of cross connections between thick filaments. So there are two different filaments in a sarcomere. There's thick filaments and thin filaments. The thick filament is section here connected by the M line. So you've got thick filaments extending from the M line out to the side here and from the M line out to the side here. Then you have thin filaments, which are connected by the Z line. And again, those are projecting out in this direction from the Z line, and then also in this direction from the Z line. So if you can see me, let's see. So you've got thick and thin filaments, kind of like, imagine this hand is thick filaments, this hand is thin filaments. They don't actually change length. So the contraction of a muscle isn't those filaments changing length. It's not them getting smaller. It's the increasing of the overlap between them. So they're kind of sliding together. And that is represented pretty well in the next image here, but we're going to focus on this anatomical image to start because I think it's labeled really nicely. So the A band here corresponds to the full length of the thick filament. And as we just discussed, that does not change. The only variable part is how much it overlaps with the thin filaments. And that depends on the degree of contraction. So if your muscle's contracting a great deal, those are going to overlap a great deal. And if it's not contracting quite as much, they're not going to overlap quite as much. The I band here corresponds to the parts that are only thin filament. So they're not overlapping with the thick filament. This part can be a little bit confusing because the I band does change in length because it's not measuring the total length of the thin filament. So it's not quite synonymous with the A band. You have A band never changes. It's always the length of the thick filament. The I band is just where the thin filament is not overlapping with the thick filament. That can be a little bit confusing, but if you spend some time with it, it should start to make sense. Next, we have the H band, which corresponds to where there are only thick filaments with no overlap of thin filaments. So the I band and the H band are kind of like two sides of the same coin. They both change in length because, again, you're just measuring the thin and thick filament portion that is not overlapping. So again, if you have your images here, you've got this portion here, maybe would be the thick filament, and this portion will be the thin filament. So you can see that when they're overlapping, this is getting smaller, and same thing with the thin filament. Again, I have a video that is probably a little bit clearer than my fingers, but we can move on from there. The M line is the site of cross connections between the thick filaments, as we said, and this is kind of like the center of the sarcomere unit. So when you see sarcomeres depicted in images, diagrams, videos, the M line pretty much always appears in the middle. And I like to think of contraction being the Z lines moving in towards the M line and that whole unit contracting, which again takes us to the Z line, which is the site of the thin filament attachment from which thin filaments are projecting out in either direction. Oh. Okay, so when a relaxed sarcomere contracts, the A band remains the same because, again, the A band is the thick filament length, and that does not change. The I band and the H band decrease in length because they are measuring the portion of the thin filament and the thick filament, respectively, that are not overlapping. So you can see here the I band is really wide. It's overlapping a little bit more, so it's getting a little bit smaller. And here there's only a small portion left where the I band, or sorry, where the thin filaments are not overlapping with the thick filaments. And the same goes for the H band here. You can see that it's fairly wide when the muscle is relaxed or when the sarcomere is relaxed. And it's getting smaller as there's more and more overlap between the thick and the thin filaments. So again, the A band remains the same length. I band and H band decrease as the sarcomere contracts. And the Z lines move closer together in towards the M line. And you can see that here in this image, the striations are actually, they're just the way the sarcomeres appear from a, like a more zoomed out or a grosser image of the muscle. And it's a really nice comparison in the future when you see it to cardiac and smooth muscle. So just keep in mind how organized this is. And those organizational units and functional units, again, are the sarcomere. So I have a video here. I hope you can hear it, but let me know if you can't. It's not playing quite yet.
This scene shows the molecular relationships of actin
No.
and myosin.
Can't see it. I think you'll have to unshare your screen and then reshare it to the screen that's projecting the video.
Oh, okay. That makes sense.
Because we can hear it but not see it.
Can
There
you
we
see?
go.
Okay.
Yep, it's going.
Pattern of the sarc. This scene shows the molecular relationships of actin and myosin relative to the banding pattern of the sarcomere and demonstrates how this relates to sarcomere contraction. Note the relationship of actin and myosin molecules relative to the banding pattern that we have discussed for the sarcomere.
Let me pause it there and just say that the actin and myosin are additional components to the sarcomere that are a little bit more minute, and they are important because that is how the filaments actually overlap. If you're wondering how they slide and how they overlap, that is the mechanism of action. I don't believe that level of detail is going to be included on the regionals, but I will check that, and if it is, then we'll give you some more information on those. And I can't hear it anymore. Let's see. That was weird. Okay, well, for now, we're just going to play it with the subtitles because I'm not really sure what happened to the sound.
Myosin filaments consist of crosslinks that bind to specific receptor sites on the actin. The cross-links pull the actin along the myosin. Note that the cross-links attach and release independently. If the cross-links acted in unison, they would all be released at once, and the myosin would be detached from the actin, allowing the sarcomere to go back to its relaxed, uncontracted state. Let us look more closely at how the cross-links slide the actin along the myosin.
Okay, we're gonna stop there because that was a little bit more detailed than I think we need, and then we got a commercial. So this is, working with it live. We didn't have the dog, but we had a commercial, so that's that. Let's move on to cardiac muscle. If you have any questions about the sarcomere, those thin and thick filaments sliding, feel free to post them in the chat or ask them in the question and answer portion after the presentation, and we'll address those for you. So the next section of the three is cardiac muscle.
Okay, we are still on the video, so you'll have to go back to your.
Thank you so much. So you can just see the Bombas sign, I guess. Let's go back to the PowerPoint. Okay.
That was a good
No?
video sharing.
Thank you. Thanks, Emmeline. Okay, so the histological morphology of cardiac muscle is similar in certain ways to skeletal muscle and different in other ways. So you have a functional syncytium, but individual cells which are either single nucleated or binucleated, and they're connected via intercalated discs. I'm sorry, I'm having trouble speaking today, apparently. Which are these darker lines here. Again, you can see the striations. That's similar to the skeletal muscle because cardiac muscle still has those sarcomeres. But at pretty regular intervals, you can see these intercalated discs, which are the darker lines. They're also very visible here. These darker lines here, intercalated discs. Unlike skeletal muscle, cardiac muscle branches. So when the skeletal muscle was very well organized and very close together, the cardiac muscle is branching and a little bit more chaotic in appearance. Another difference is that the nuclei are centrally located. So you can see that here in this image. They're within the cardiac muscle fibers. They're not peripherally located on the sides like the skeletal muscle. And you can see that here as well. They're nice and plump and they're right in the center of the muscle fibers. Again, you can see that here, located in the center of the muscle fibers with those intercalated discs. And they are still striated, just like the skeletal muscle. And you can see that in this image with these striations. It's a little bit harder to tell in these histological photos. So the function of cardiac muscle is under involuntary control, as you probably can guess. You don't really decide when your heart beats, it just kind of does it for you. It speeds up when you need more oxygen, slows down when you don't. It's more complicated than that, but again, you don't voluntarily make the decision to contract your heart. It just kind of, it's under involuntary control. And it contracts to pump blood through the circulatory system so that there is oxygen delivered to all your tissues and that waste is taken away from those tissues and disposed of. The typical locations of cardiac muscle is fairly self-explanatory. It's in the heart, but it's also in the beginning portion of the great vessels. So the aorta, where it attaches to the heart, that also has cardiac muscle involved. And the heart is up here. You've got the epicardium, myocardium, and endocardium. Some way to remember this is that endo typically is on the inside, myo is kind of from middle, and epi is more superficial. And if we were to go back to the connective tissue of the skeletal muscle, it would be similar. And last but not least, we have smooth muscle. So this is the third type of muscle found in the body. It is a little bit different than cardiac and skeletal. It's small with spindle-shaped cells. So you can see here, they kind of look like elongated croissants, I guess, if you were to flatten it out. Thicker in the middle, narrow at the ends, with a single central nucleus. There are no striations, so that's a big difference between smooth muscle and cardiac and skeletal, which both have the striations. And while smooth muscle does have gap junctions and actin and myosin proteins, just like cardiac and skeletal muscle, they're not arranged in the same way. So the functional components are there, but again, they're arranged a little bit differently. The function of smooth muscle, just like the cardiac muscle, is under involuntary control. And it's found in hollow viscera and blood vessels, your eye, erector pili muscles, and your skin. So hollow visceral organs would be like your stomach has smooth muscle, as you can see here in this diagram. And just like the cardiac muscle, you don't decide when to contract your stomach. It kind of contracts and relaxes to mix that food, help digest it. The blood vessels also are under involuntary control to relax and contract, or dilate and contract, depending on certain factors like your blood pressure. You have smooth muscle in your eye to contract and relax your pupil and allow you to see further and closer in a process called accommodation. And those are all processes that you don't consciously think of. They just kind of happen based on a very complex system of feedback and just trying to make sure that your body stays in homeostasis and has the nutrients and oxygen that it needs. The erector pili muscles in the skin are what make your hair stand on end. So if you're cold, your hair does kind of stand out from your body, and that's to trap some warmth and keep you a little bit warmer. But again, that is something that you do not have under voluntary control. You don't decide to have your hair stand on end. It just happens when it needs to, basically. So they're continuously ongoing. And unlike cardiac muscle and skeletal muscle, it typically involves a maintenance of steady state or tonic force for extended periods of time. So your heart is very powerful. It contracts and then it relaxes. That goes for your skeletal muscles as well. If you're picking something up, your bicep contracts, and then if you put it down, it relaxes. And those are pretty definitive, like yes or no's. Again, there are different varying degrees, like on how much you can contract your skeletal muscle. Your cardiac muscle, again, is under involuntary control, so you cannot decide that. But smooth muscle is unique in that it does kind of have that maintenance of a steady tonic force to different degrees, depending on where you find the smooth muscle. So I kind of like this chart here. It compares sphincters, which you can imagine want to relax and tighten at specific times. You don't want certain sphincters to relax, lest you end up in pretty awkward social situations. Your blood vessels have a more tonic or steady tone. And that makes sense because if your blood vessels are completely relaxed, the volume of the vessel, I guess, or the volume of your circulatory system would increase and your blood pressure would drop. So you do want to have kind of a tonic, continuous force on the blood vessels so that you do have adequate blood pressure control. Your stomach and intestines here have a more cyclic contraction and relaxation, which makes sense because you're not always eating, you're not always moving food through the digestive tract, in constant degrees. And then you have the esophagus and the urinary bladder here, which you can see is normally relaxed because you need your esophagus to be relaxed, lest you not be able to breathe, not be able to swallow. And your urinary bladder is also relaxed because that detrusor muscle, which is a smooth muscle in the walls of your bladder, needs to be relaxed when you're trying to hold urine. And then it contracts when you're expelling the urine. So even though smooth muscle does have a tonic kind of steady force, generally speaking, you can see there is some variation depending on where you find that skeletal muscle. Smooth muscle. I would spend some time with this chart and try to think of other examples where, you have like a steady state, or you have normally contracted and then periods of relaxation, or the opposite, normally relaxed with periods of contracture, and just try to think of other examples in the body. It'll help you kind of understand the process and the function of smooth muscle. So that was the 3 different types of muscle you find in the body. The skeletal muscle and those sarcomeres, I would spend a little bit more time with that. But I'm happy to try to answer any questions now. Let's see.
Kate, could I suggest, could you just go briefly back to skeletal, cardiac, and smooth muscle, those slides, and just go over the histologic morphology, what makes them unique comparatively? Just run through skeletal, cardiac, smooth, just to give a nice recap of that. Thank you.
Yeah, I think that's a good idea. So there are 3 slides: the skeletal muscle, smooth muscle, and cardiac muscle. They look like this in this layout, and I've kind of laid them out similarly too, so you can go and compare them. But skeletal muscle is multinucleated, whereas cardiac muscle has 1 or 2 nuclei, and smooth muscle has 1. So you're decreasing the number of nuclei. Skeletal muscle has peripherally located nuclei, whereas cardiac and smooth muscle have centrally located nuclei. Skeletal muscle is long and unbranched, and it ends up being very organized like this. They kind of look like cornfields if you were flying over them. It's kind of how I think of it. Cardiac muscle is branched, so the organization looks a little bit more chaotic and not quite as like cornrow straight. Let's see. Oh, and then smooth muscle are those like elongated crescent shaped cells. Skeletal and cardiac muscle have striations where smooth muscle does not. Let's see, did I miss anything? But they all have, remember, they all have actin and myosin, but the smooth muscle actin and myosin are just arranged in a little bit different way than the skeletal and the cardiac sarcomeres. Skeletal muscle is under voluntary control, whereas cardiac and smooth muscle are under involuntary control. And then to review the locations, if it's a grossly named muscle, so if it's a muscle that you can find labeled on a diagram, then it is likely a skeletal muscle. A better way to think of it, though, is if it's a muscle that you can decide to move, or if it's a muscle that contracts when you make a voluntary movement, then it is a skeletal muscle. Kind of a weird, not exception, but a note to this is that your diaphragm, you can decide to breathe, you can decide to contract your diaphragm, but it is also under involuntary control, so that is a little bit more of a complex situation. But for the most part, you're not really thinking about contracting your diaphragm, but you can choose to, so that's a unique situation. And then let's find the other 2 slides here. Cardiac muscle here. So again, we said cardiac muscle has 1 to 2 nuclei, branched cells. The nuclei are located in the center, just like smooth muscle. And like cardiac or like skeletal muscle, it is striated. Another difference between cardiac muscle and smooth and skeletal is that cardiac muscle is the only type that has intercalated discs, as you can see here. And that is where the cells are connected, just kind of like end to end. As I said before, cardiac muscle is under involuntary control, as is smooth muscle. And it's located in the heart and the beginning portion of the great vessels, so the pulmonary artery and the aorta. Sorry, that probably is pulmonary vein and aorta. And then smooth muscle is, last but not least, we have those small spindle-shaped cells. For those of you who have never seen a spindle before, because that might be a little bit before your time, it's probably before mine. I just think of them kind of like elongated croissants, flattened out croissants with centrally located nuclei and a single nuclei, unlike smooth and skeletal. There are no striations, unlike cardiac and skeletal, which both have striations. And again, all 3 of them have actin and myosin proteins, but they're arranged differently in smooth muscle than they are in the sarcomere of skeletal muscle. Smooth muscle is under involuntary control, just like cardiac muscle, and it tends to maintain a steady tonic force, but as we discussed, the degree of steady force does vary depending on where you find the smooth muscle. So those are just kind of like high-level overviews of the differences and similarities between the three types of muscle. And again, if you compared these notes, I did organize them to be, laid out in the same way. So it should be a little bit easier to compare them on your own time if you'd like.
Thank you, Kate. That was really helpful. Michael has a question. Michael, you can go ahead and unmute and ask.
Okay, I had a couple questions. For how do muscles go through protein synthesis? Like I know they have the nuclei necessary for that, but do they have like the rough endoplasmic reticulum, or like how do they synthesize those proteins? Also, a follow-up question was like the satellite cells, they're like muscle stem cells, you said, but do they, you said they're like in muscle repair, are they also in muscle growth? Or is it only in like muscle repair?
So please correct me if I'm incorrect on this, but the satellite cells, so stem cells are what you're talking, from what I understand your question is, do they just help with growth, or are they the cells that grow? Stem cells are the cells that have the ability to differentiate into adult or mature cells. So they're not support cells. They are actually stem cells. They're not supporting repair. They are replacing damaged myocytes. So I don't know, Dr. Frank, or is that an adequate explanation?
Yeah, I think for where you put it at for what satellite cells are responsible for, I think sounds good. Think of how when you work out and then you damage this muscle tissue and it needs to be repaired. So because that's something that we're able to do, these satellite cells are going to be really important for that.
Dania asks, can you quickly explain the striations for cardiac and skeletal muscle?
Yeah, so striations are, they're a description of what you see and how you see the sarcomeres organized. So when you can't see in this, so this is a good picture here. In this picture, you can't see individual sarcomeres, but the collection of sarcomeres are arranged in such a way that create these alternating lines of dark and light. So striations are just the way we've labeled a description of how they look, basically. But striations are corresponding to sarcomeres, which is why, because smooth muscle has those actin and myosin proteins arranged differently, they don't have striations. Whereas skeletal muscle and cardiac muscle have those sarcomeres arranged in ways that do form these alternating patterns of dark and white lines. And I think if you go to, let's see this photo here, this is a nice photo here. You can see the dark lines and the light lines are corresponding to the A band and the I band, roughly. And again, there's like little image, there's, obviously going to be an area here where they overlap, but striations are a little bit more zoomed out, and they're more of a description of what you see as a whole rather than on a sarcomere level.
Sorry, how do the muscle cells, like, how do they process or create the proteins they need? Without, or if they only have nucleuses, or nuclei, do they also have other cell components that help them process or make proteins?
Yeah, so the nuclei is we talk about the nuclei a lot when we're talking about the three different kinds of muscle, because it's just an easy point to compare and contrast between the three of them. There are other components to the cells. There's not just a cytoplasm and a nucleus, but the scope of that wasn't covered in this? That is an interesting question, but there are additional components to the muscle cells that do help them, function and produce all the nutrients and carry out all the functions they need to do what they need to do.
Yeah,
Images don't really show that, but
yeah, it's a good question. More of a physiology one, so not something that will show up on your exam, but still a good question. So for those of you who are going through basic biology and kind of learning how that occurs, then this is going to be really your ribosomes coming into action. Again, that's not something you're going to see histologically, so not something that you need to worry about identifying or even describing, but the protein synthesis you guys can look up is a sort of standard transcription and translation process. But I like where you guys are going at and kind of figuring out what you know and how you can relate that to your other classes, whether it be biology or physiology. That's, asking just questions is a really good way to really get the full scope of something you're trying to learn. So I'm glad you guys are doing that.
Okay, sorry, one more question. So I've done a little bit of study on this tissue before, and I remember seeing a protein called titin. I'm not sure if that's how you pronounce it, but when it said like when titin is stretched, it starts exerting tension strength. Like, so the more it's stretched, the more force it exerts. If you took that out of muscle cells, would they still be able to exert force when contracting? I can't remember what part of the sarcomere they were inside of or connected to when it was contracting, but it was when the sarcomeres contracted, they would pull on the titin and stretch it, and then it would have that tensile strength. But I was curious if you took that away, if it would even exert force at all.
I personally don't know anything about that, so I can't really comment. For a lot of these functions that we do have, there's usually several compensatory factors. So it could be that there are others besides the one that you mentioned that might compensate for that, but I'm not quite sure. But that could be a good research question. I know tensile strength is something, and if you're interested in kinesiology research, that's definitely a hot topic there. So definitely a good question. Anything to add, Dr. Frank?
I just put something up that's gives a little bit of a description of it, Michael. You're going down a whole avenue of kinesiology and muscle physiology. So, but at least that gives you a little bit of an idea of what it's doing. Again, not part of our focus for the Anato-Bee competition. But certainly, if you're going to be studying it, you will learn about all of these different things, but it's not our focus for the Anato-Bee. So are there any other questions for Kate? Okay, I don't see any. So Kate, I will let you off the hook here. It was a heavy lift.
Yeah, I just want to say, like, Michael, thank you for asking those questions. They are really interesting questions. It has been almost 10 years since I studied that in college. So I appreciate your patience. But if you are interested in it, I highly recommend watching some videos and doing some reading on it, because it is really fascinating stuff.
All right. Okay, so we are going to shift gears a little bit again, and I'm going to introduce our third presenter. Her name is Natalie Saliba, and she's going to be presenting on the embryology of the musculoskeletal system. So Natalie is a graduate of the University of Alabama at Birmingham's neuroscience program and a current medical student at Edward Via College of Osteopathic Medicine in Auburn, Indiana. In her free time, Natalie loves spending time with her new nephew, going on walks with her dog, and creating art. Natalie's favorite part of anatomy is head and neck anatomy. So without further ado, Natalie, the floor is yours.
Okay, I will share my screen. Let me know if it pops up. Can y'all see it? Okay, good. So I'm Natalie. I'm a second year at VCOM Auburn, and this is going to be the embryology of what everyone else just talked about with the musculoskeletal system. So we only have 2 learning objectives. So basically just describing how the limb is formed from the mesenchyme and the somatic mesoderm, and then describing the somite formation and the differentiation of the somites into sclerotomes, and dermomyotomes. Okay, so basically just think of embryology as a story. And so from the very beginning, there's an embryo, which is right here. And the embryo is just a flat sheet of cells, and it's going to undergo embryonic folding. So it's going to fold from the top and the bottom and then towards the sides. You can see that happening right here. And it forms a C shape as it closes. And you can see it closing right here. The blue is coming around. And it is forming a tube within a tube, basically. So this blue is going to be the ectoderm, so the outside. And then the red is the mesoderm. And then this little tube inside the big tube is the gut tube. And that's made of endoderm. So the ectoderm, mesoderm, and the endoderm are the 3 layers. And then the basic high yield is that the musculoskeletal system comes from the mesoderm, which is the red right here. And so here's like another viewpoint of it, like actually implanting into the uterus. You can see like I twisted this image so you can see the embryo, how it is right here. And this just shows how the different layers and what they become. So basically the mesoderm is going to be the skeletal and muscular system. But it makes sense that like the endoderm becomes the guts. And then the ectoderm becomes the outside. So like the skin, nails, and hair. You can see that right here. All right, so for this picture that we just looked at, I made a little graphic right here because the mesoderm actually has 3 different layers to it. And so the layers are right here, the periaxial mesoderm, the intermediate mesoderm, and then the lateral plate mesoderm. And right here is the neural tube, and then here's the notochord that we have over here. And then the gut tube is right here. And we'll go through what these become later. But those are the 3 layers of the mesoderm. So then after you have the 3 layers, you focus in on the periaxial mesoderm, which is the pink square. And then that is going to divide even further into the somites. And the somites basically just form along the neural tube from cranial to caudal, which just means head to tail. And these somites form along this the neural tube, and then as they form, they also divide into 3 different layers. So basically, it's just mesoderm dividing and dividing and dividing. So the dermatome forms the dermis and the subcutaneous tissue, which would be different from the epidermis, which is going to be the ectoderm right here, the outside. And then the myotome right here is going to form the muscles. And then the sclerotome is going to form the vertebrae and the spine and ribs. And so derm means skin, so you can think of the dermis and the subcu. Myo means muscle, so you can think of the muscles. And then sclero just means hard, so you can think of that as like the bones of the spine and the ribs. And then so now that we have more of like the trunk bones and the muscles and the skin, the arms and the legs actually come from the lateral plate mesoderm. So the bones in your arms and legs come from that. And the lateral plate mesoderm is right here again. So at week 6, the mesoderm here forms into hyaline cartilage that will later develop into bone. Okay, so here is the limb buds forming. So if you go right here, think of yourself as like a tube right here. So as this is like a flat section, just think of yourself as a tube, and we'll go back to that picture. So the limb buds form as a thickened portion of the ectoderm. So that ectoderm, the outside part, thickens, and it's called the apical ectodermal ridge. And so the limb buds form from the proximal to distal. So they form coming from the inside of the tube and just elongate outwards. And as they elongate, the cell division stops as the distance grows farther away from the embryo. And then the limb bud resembles flat paddles. And then these paddles will form constrictions at midway points, which would make the knees and the elbows. And then the cell death or apoptosis will occur at these areas to allow for the fingers and the toes to develop towards the end of the buds. And you can see the limb buds forming here. And so here is what I was talking about earlier, basically putting it all together. The lateral plate mesoderm right here, it will extend out into the bud. So if these are your little arms and legs, it's going to all extend outwards. Oops, except for the scleroderm is going to stay like inside the tube or the trunk. So this lateral plate is going to extend outwards and it's become this black line, and that's going to be the bones of your arms and legs. Whereas when the myotome and dermatome comes out, the myotome is going to stay more towards the inner, towards the bone, and then the dermatome is going to stay more like outside towards the ectoderm, which becomes the epidermis. So it kind of makes sense of why your body is formed the way it does, because of how these will extend outwards. And then right here, I mentioned the neural tube earlier. So the neural tube becomes the spinal cord in the brain, which makes sense of why the sclerotome will like wrap around it as the bones. And then the notochord forms the disc in between your vertebrae. And so this is just basically why is this important? Like, what is the actual meaning of a dermatome and myotome, which we talk a lot about during medical school. And it's a lot of more of like our clinical correlations and how doctors use it in the real world. So let's say for your dermatomes, if a patient can't feel anything around their thumb or their lateral forearm, which is right here, this little orange part, then there must be a problem at C5 and C6. So basically saying like when embryology was happening, the C5 and C6 right here, if we go back to this, how it kind of looks like a spinal cord right here, that portion is going to extend out into the limb bud right here. And it's going to go all the way down to this part of the arm. So that ties into that spinal nerve. And so let's say if you can't feel that section, it obviously shows that there's a problem up here at that spinal nerve in your neck. And then for the myotomes are just your functions. So let's say if a patient doesn't have the reflex at the knee when it's hit with a reflex hammer, then you can look over here. Well, this one is a little bit different because I couldn't find a good myotome map. But for the myotomes, it's a completely separate map. But the L4 would be at the knee. So if they don't have that reflex, then you know that that muscle has a problem, and that problem would be at L4, which is in the lumbar section of your back. And then this is just a fun clinical correlation of why this is important. It's not for testing purposes. And then that's all I have.
Hey, do we have questions for Natalie?
Sorry.
Yes, there was. Oh, who wants to go first?
William, you
Did
can go first. We'll get Michael after you.
All right, so there was like what was the orange circles in the diagram?
Mhm.
Because I don't think we talked about those.
Yeah, those are just as the 3 layers. There is no function that correlates to these learning objectives. So that's just a 3rd layer. You can just kind of omit that for right now.
Yeah, I was just curious, but what do they become though?
Dr. Pesquera?
So that's going to be important for, I believe it's kidney development and reproductive structures.
Uh,
A lot of glands.
so like stuff that is, I think appears on the lateral sides.
I'm sorry, can you repeat your question? I don't think.
So is it like responsible generally for stuff that we have like one of on each side?
Like paired. Mhm.
Yeah.
Yeah.
Yeah, that's a really good thing to notice. So we've only got one neural tube here, for example, and one notochord, and think about how that makes sense with our spinal cord development. So that's a really good point that you just put out there, is that we are paired. So having 2 things on either side. So having our reproductive or our gonadal structures are going to be paired. Having our kidneys, we do have 2 of those, and those are paired. And same thing with our limbs, is that we've got 2 of those on either side, and seeing how that develops from our these paraxial mesoderm bilaterally on either side. And then our lateral plate mesoderm it's kind of that one segment, but you can see that you can find that bilaterally and how that would contribute to development on either side.
Okay.
That's
Thanks.
a really good question.
Yeah, I had a follow-up question to that. What differentiates into like the liver and those organs which don't have paired structures?
So that is how we were talking about this gut tube that forms. That is the endoderm right here. And that's going to become the digestive system, the liver, pancreas, lungs.
Okay, and then I also for the dermatomes, do they also become the or the dermis subcutaneous? Do they become the epidermis? And then also, does that include the nerves running through the dermis or around the dermis and like the subcutaneous layer? Or is it just the connective tissue part of that?
So
I
the
think
dermatomes are
yeah, just
gonna
read
be
about
the,
these.
what'd you say, Dr. Pesquera?
I think it'd be good if you just define sort of what a dermatome and a myotome is again, to start, and then go with what you were saying.
Okay. So the dermatome is just a portion of the somite that forms the dermis and the subcu tissue. And then the myotome is going to form the muscles. But you have this outside covering the entire time, which is the ectoderm, which is going to form the epidermis. And what was your other, is that the whole question?
The other was, does it also differentiate into nervous tissue, or is it just the connective tissue part of that? For the dermatomes and also the other, like the mesoderm and stuff.
Correct me if I'm wrong, but I think the dermatome is just going to stay as the muscles and like the subcu, or not the muscles. The dermatome is going to stay as like the subcu, and the dermis, while as the ectoderm, is going to form the nervous system for that area. Right, Dr. Pesquera?
Yeah, so this is a really good picture that you have here showing in terms of what is becoming what. That's a sort of an important thing I think that you're bringing up, is that when we're saying the dermatome map, for example, so the dermatome itself that we were describing is more of how those structures are developing from there, but sort of the clinical correlate we put to there is where the nervous system structures that are associated with those levels are developing from. So that's an important distinction, is that, if you're breaking it down into mesoderm versus ectoderm, then those are going to be different. But if you're testing clinically that dermatome segment, if you can go to that, I think it was the last slide that you had, Natalie. And so this map is sort of showing you in terms of what levels then for nerves are associated with the dermatome level at that region. So like Natalie was saying, is clinically, if you were to touch, for example, the lateral part of your forearm, then you can see that C5, C6, for example. So this is sort of tying in your question in terms of the mesoderm and the ectoderm coming together there. Another thing I can point out while we're just over here is when you guys are studying on that dermatome map, if you guys happen to have an interest in dermatomes and you're studying them, this map to me looks like more of the clinical version of the map, but there are two accounts that are very popular. This account seems to be more clinically relevant in adults, but there's another map that you might find that looks completely different than this one, and it's based off of the embryological formation. So this one we tend to focus on more because we care about more of the clinical presentation than we do the embryology at that point. So just keep that in mind as you guys are studying, that you might find maps that look completely different from each other.
Natalie, could you go to the previous slide? Okay, where you were talking about the limb bud and you're talking about the myotome and dermatome. There is a part of the neural tube or part of the nervous system, which you didn't talk about, which were neural crest cells that are part of the nervous system. And that is also going to follow those dermatomes and myotomes out into the limb buds. And that's what really creates all of the nerves that you have in not only your arms and legs, but in the wall of your body. Okay, so there's always a little bit more to the story, and so you chose wisely to keep it to the very germane points, but there's always more. When we go back to the liver and pancreas, you were asking about that. The main part, which we call the parenchyma of like the liver and pancreas, they're derived from endoderm, but the outer part is derived from mesoderm. So things aren't so easy. Things aren't just one for one. There, certain things are created by different parts of endoderm or ectoderm and mesoderm. And so when we say we get into the weeds, you can really get into the weeds with embryology. So we're trying to give you the 30,000 foot view here. And but I do encourage you, if you get jazzed about embryology like I do, that it's certainly worth going in and doing a little bit deeper dive. So really great questions. Again, we're just trying to keep it to the things that are germane to what you need to know for this competition. Dr. Proskura, can you add to that at all?
I was just going to say that it's coming your way. So our next tutoring session is actually going to be all about nervous system. And just like today, how we covered all anatomy, embryology, histology about the muscles, then you'll actually get more of this information. I know we were kind of touching at the nervous system today because it's important. It's innervating our muscles. So of course it comes up. We're a whole system, so they are all tied together. And yeah, so I think that's great that you're already a step ahead and thinking about that, because we'll be right there next session. And as far as the gut tube and development, then you'll be getting that in another session as well. I think that one's quite a few weeks down the road, though. Does anyone else have any other questions, or for any of our presenters today, any questions about their experience in med school or in undergrad? All right. Well, that might be just about all we have today, unless you guys have other questions that come in, but thank you everyone again for joining. Again, our next session is going to be after Thanksgiving, so I'm very grateful for all of you for being here. Oh, before I shut you guys all off, there's one question.
Yeah.
Any of us have experience in psychology?
I mean, it is on the MCAT, which is like the test that you take before, it's like the test you take to get into medical school. So I think we all had to take Psych 101 in college, and then study a little bit for it for the MCAT, but that's like, that's pretty much as far as it normally goes. Unless you go into psychiatry, that is a residency you could do after medical school. Psychiatric. No, I don't have any experience with psychiatry in particular.
Right. I would encourage you, if any of you guys are looking at any specialties, a lot of us aren't clinicians quite yet, and I'm not at all. So what I would say is if there's any specialty that you're interested in going into would be to maybe reach out to someone local in your area that does that and ask if they'd let a high school rotation come through, see what they're willing to do there. I think that's a really good stepping stone for figuring out where you want to be and kind of help you along your journey. So all right, that's all I have for today. So again, thank you for joining us. We'll meet again in about 2 weeks. And everybody have a great Thanksgiving.
Take care.
Thank you both.
Yep.
Thanks, everyone.
Great job, everyone.